All right, so good morning. Today we'll talk about pharmacotherapy of liver cirrhosis and its complications. So, as you know, there are many complications of liver cirrhosis. So, the pharmacotherapy is like kind of scattered depending on what complication we're talking about. So, our learning objectives would be to briefly revisit the pathophysiology of liver cirrhosis and its complications, which you already know, I think. And then we will rationalize the pharmacotherapy in the management of liver cirrhosis and its complications, and we will correlate the pharmacological actions of the drugs used in the management of liver cirrhosis and its complications. And again, please note that only pharmacologic interventions are discussed here in today's lecture. Non-pharmacological therapies are very important in the management of cirrhosis and its complications. But they are not our today's objective. So we won't discuss those things. And probably they will be discussed with clinicians and by the surgeons. Some things are done by surgeons, others are done by gastroenterologists. So they will discuss in their respective lectures. Okay. So what is cirrhosis?
Fibrosis of the liver.
Good, fibrosis of the liver. And so there is some insult to the liver. It's a chronic insult. And it's a diffuse insult to the whole liver, not just localized in one part. So, and with the chronic, so there is fibrosis. So now what happens in the late stage of this diffuse hepatic process, in which there's progressive hepatic fibrosis, and that leads to distortion of the normal hepatic architecture. And as you know, these hepatocytes are labile cells, so where they are like stimulated, they can regenerate. So as a result, there is some regeneration, but they are because there's fibrosis, so there's architectural distortion. So the regenerated nodules are structurally kind of abnormal. There's a haphazard pattern. And that you will do more details in pathology. You've done that. So you know, so there's formation of structurally abnormal regenerated nodules. In brief, you can say diffuse hepatic fibrosis with regenerated nodules. And then there are different patterns of cirrhosis depending on what is the etiology, that details you will do in pathology. There's a macronodular and micronodular, and probably you have done that. And pathology, I'm sure you must have done that. So obviously in the advanced stages, this is irreversible. And patient with cirrhosis, once they develop cirrhosis, so the function is compromised. So obviously, when a liver has lots of functions, so when they are compromised, so there are complications, and life expectancy is also reduced because of that. So what are normal functions of liver?
Detoxify the body, mostly makes proteins, albumin, and immunoglobulins, bioregulation,
Anything else?
production of energy,
Proper.
clothing factor,
Clotting fat is good. Anything else?
Detoxify the
Detoxifies the.
when there's consumption of alcohol for intoxication.
Okay. Anything from there? The top corner, top left corner? Nothing? Okay. So there are lots of functions. And you know better. So what can we do? We can either prevent. The first thing, because as you know, in advanced, if it's irreversible liver, so important, so it's better. Prevention is better than cure. Huh? So we try to prevent cirrhosis. And once cirrhosis develops, then we try to treat cirrhosis and we try to treat its complications. Unfortunately, we don't have many treatments for cirrhosis itself. And so all these things will include pharmacotherapy as well as non-pharmacologic measures. And they are very important, as I said, but they are not part of our learning objective today. Okay. Settled?
yeah,
So we'll focus more on pharmacotherapy and we will ignore the non-pharmacologic measures. So the general approach is we provide treatment for the underlying condition. Because as we said, this is a result of chronic insult to the liver that stimulates the fibrosis. And what is the pathogenesis? That I'm sure you will do in the following. We used to have PBL on chronic liver disease cirrhosis, and that was very good. And we used to do the pathophysiology and pathogenesis, all of those things. I don't know. Probably this year you won't have that PBL, fortunately. Yeah. So you have only I think 4 PBLs. So that one is not there. That should have been there. So you should be, because this is very important. This will be tested again and again throughout your medical career. Like as long as you are doing like MBBS and residency in internal medicine or in surgery, anything, unless you become a specialist of something, you do a fellowship, probably then you may not be tested. On this thing. Still, all of your patients, even if you're a cardiologist, your patients can have cirrhosis. Even if you're gynecologist, your patients can have cirrhosis. So you should know about that. This will be tested again and again in different exams throughout your life. So you should understand, especially the drugs which can cause hepatotoxicity and the drugs which should be avoided in patients with cirrhosis. That if you want to practice medicine in any subspecialty, you should know that. Okay, so in this case, the general approach is we try to treat the underlying condition which is causing cirrhosis or which is causing chronic liver disease or which can produce potentially liver fibrosis. So for example, someone who has Hep C infection, so we try to HCV with antiviral drugs and we try to reduce the hepatotoxic influences. This is, and we try to prevent, recognize, and treat possible complications in time, and we avoid hepatotoxic substances, for example, alcohol, medications such as NSAIDs in patients who are developing liver fibrosis or who have chronic liver disease. And we also provide them some routine vaccinations, those who have cirrhosis, so they have some immunological dysfunctions. So we vaccinate them from pneumococcal infections. We give them hepatitis A vaccine, hepatitis B vaccine, influenza vaccine, tetanus vaccine. So they need to get their routine vaccinations. And they need to have balanced diet, adequate caloric intake, and no protein restriction. And past, they used to advise protein restriction, but now they say there's no need to restrict proteins, and there should be adequate caloric intake. So how do we prevent cirrhosis? So depending on the etiology, okay. So we will discuss briefly some etiologies and the possible preventive measures. Okay. So autoimmune hepatitis, how can you prevent that? Or someone who has developed autoimmune hepatitis, now how can you prevent cirrhosis in those patients? Yeah, immunosuppression. So you can give prednisone as a therapy. And because you will do like when the clinicians talk about autoimmune hepatitis, they'll talk about their treatment. But in general, immunosuppression like prednisone as a therapy. Someone who had B or Hep C. Yeah, so one is you can prevent hepatitis B by vaccination. So we have hepatitis B vaccination available. So if you do vaccination, so that can effectively prevent infection. But somebody who's infected with hepatitis B or Hep C, then you have antiviral drugs available, and which like interferon and other antiviral drugs, which I'm sure have you done the lecture on. Okay, so you have antiviral drugs lecture on. You have
Pharma or?
I'm pharma lecture,
No.
but you haven't scheduled now.
Yeah, for them, Sunday was postponed.
Yeah, but it will be there, huh? So you do those all antiviral drugs which are used in Hep B and Hep C. Someone who's hemochromatosis, they can also develop cirrhosis because what is hemochromatosis? Iron overload, huh? And that can accumulate in different organs and then can lead to dysfunction of those organs, including liver. You know, fat is there, so that can lead to cirrhosis. So what can you do with?
The doctor said interferon no longer is given, and instead they have something.
Peg interferon?
I don't know the doctor said the interferon is no longer useful and use it.
Which Hep B and Hep C?
Yeah, Pepsi.
Hep C. So probably in Hep B. So you'll do it in your antiviral drugs. So which ones are these days? Like which ones? Because every time you like you're developing new drugs, so they might have some new agents. So you will cover in. I don't want to talk about that part. But pegylated interferon were part of the management of these viral hepatitis. Which one it is, you will do it. So hemochromatosis, so what can you do for hemochromatosis?
And
Iron chelating agent. And the other thing is, yes, so you can remove periodically remove some blood. They call it phlebotomy. So either you can do phlebotomy. So periodically you remove some blood, and the other thing is you can give iron chelators. And I think this part was done in your hemong block and primary biliary cholangitis. You've done that. Previously, you used to call it primary biliary cirrhosis. Now they call it primary biliary cholangitis. So again, it's because of the biliary duct problem, which leads to eventually cirrhosis, so cholangitis and then cirrhosis. So there's some role of sodium-oxycholic acid and obeticholic acid, which can delay this problem. Wilson disease. Have you done Wilson disease?
yeah,
Yeah, so copper. So you can give copper chelating agents. Good. So you can give copper chelators like penicillamine, trantine. So these are copper chelating agents. You can also give, probably along with them, you also give zinc salts, which decrease the gut absorption of copper. And I hope you know about details of the Wilson disease. So Wilson disease is only limited to liver, or does it affect any other organs? Uh, Can you name one? Yeah, so good. Alcohol associated liver disease. So, and this one, what can you do? Good. So you stop alcohol. But then there's something called non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, like NFLD and NASH. They are important causes of chronic liver disease and cirrhosis, especially in the developed world, including Saudi Arabia. So you should learn about them as well. So once there is cirrhosis, then how do we treat cirrhosis? Because it's a fibrosis and advanced stages, it's irreversible. So unfortunately, we don't have approved anti-fibrotic therapies for liver cirrhosis. So once it is in initial stages, if you prevent, if you treat the underlying etiology, probably you can prevent cirrhosis. But in advanced stages, at the moment, we don't have. There are certain anti-fibrotic drugs being used in clinical trials, and like in patients with NASH, patients with HCV, but there are none in the clinical practice at the moment. But hopefully, sooner we will get some drugs which can prevent reverse fibrosis. Like there is one drug which is used in lung fibrosis, and that same drug is in trial for the liver fibrosis in HCV patients, but again not in clinical use. So the only treatment that we have is liver transplant, which again probably the surgeons will talk about. So once there is cirrhosis, so the only option is you do liver transplant. So what we try to do, we try to prevent the complications, because once there's cirrhosis, so there are complications. So and there are many different types of management. So we'll talk about pharmacotherapy for the management of cirrhotic complications. And the main drugs that include briefly here are non-selective beta blockers, for example, propranolol, and they are used to lower the portal pressure and prevent variceal bleeding. So obviously, as you know, there's portal hypertension and there are esophageal varices. So to prevent variceal bleeding and to reduce the portal pressure. So non-selective beta blockers are an important part of pharmacotherapy. Similarly, some diuretics like spironolactone and furosemide to manage ascites and edema in these patients with cirrhosis and hypoliminemia as well. And lactulose is very important for these patients to manage their hepatic encephalopathy.
do we give them all
or depending on what.
depending on the complications. But like I'm saying, these drugs are commonly, you see these drugs commonly being used in these patients. We'll go over these drugs again. So in the next few slides, so what are different complications of liver cirrhosis? Can you name some complications?
I thought therapy is for the hypertension and
Splenomegaly. Now, something from the backside. From the students on those top benches, huh? Complications of liver cirrhosis. Edema, ascites, good. Anything from there, from that corner? Good, very good. Anything else?
Jaundice.
Hmm?
Jaundice.
Anything from there? Complications of portal hypertension? Varices. So we talked about portal hypertension, which can lead to splenomegaly, which can lead to esophageal varices, and which can lead to upper GI bleeding. So okay, besides portal hypertension, some but you mentioned jaundice as well. So okay, good. Pulmonary problems. What sort of problems? Any idea? No.
I'm not sure exactly, but someone can die.
Yeah. So there are complications of the phenomena called hepatopulmonary syndrome that can develop. Yes, you were saying something here. Cancer, very good. So very good. So these patients who have chronic liver disease cirrhosis, they are at a high risk of developing hepatocellular carcinoma or hepatoma. So hepatocellular carcinoma is like an important complication of liver cirrhosis. Okay, what else? Hmm? Hypotension, yes, because they have fluid retention, they are in overload, but at the same time, their intravascular volume is reduced, and they can go in hypertension towards the late stage, I would say.
Congestive heart failure.
Sorry?
Congestive heart failure.
Congestive heart failure can happen. Yes, so there are circulatory problems. Congestive heart failure can lead to cirrhosis as well. So it can be one etiology as well sometimes. You must have done
The breathing problem.
breathing problem. Yes, very good. Because it's involved in synthesis of clotting factors. So there will be breathing problems. It also affects the function of platelets. So yes, so there are many complications like portal hypertension, the first thing, and that leads to portosystemic shunts, which leads to esophageal varices, hypersplenism or splenomegaly, ascites, spontaneous spectral peritonitis. This is very important. Have you heard this term? No? Spontaneous spectral peritonitis. So what happens? These patients can develop peritonitis. You know what is peritonitis? Inflammation of the peritoneum. So bacterial peritonitis, that means there's infection in the peritoneal cavity. Okay, and there's inflammation because of the peritoneal. Spontaneous means it was all on its own, like all of a sudden, with no. Otherwise, like suppose if there's a perforation, GI perforation, so the GI flora leaks into the peritoneum with the contents, so that leads to peritonitis as well as infection. So, or if this tumor, something like that, but without any focal cause or surgically correctable cause, if there's ascites fluid and if that fluid develops kind of infection, that happens in these patients, that's called spontaneous bacterial peritonitis. It's important complications, and hopefully you learn more about that. And this is important. Huh? Hepatic encephalopathy. This is also very important because you know detoxifies lots of things. So there are many neurotoxic substances which don't get detoxified. They get shunted. They bypass the liver and go to systemic circulation because of those shunts, and they lead to dysfunction in our brain, and that leads to hepatic encephalopathy. Hyperbilirubinemia or jaundice, hepatorenal syndrome, which is very important, and again it has like a bad prognostic. It's a bad prognostic factor. It can lead to increased mortality. Hepatorenal syndrome, coagulopathies, circulatory and cardiovascular issues, and there are many other metabolic endocrine and structural determinants because usually they can develop diabetes, they can develop adrenal insufficiency, many things can happen. And last but not the least, hepatocellular carcinoma. So all these are yeah, patients with cirrhosis, they can have renal dysfunction as usually an acute phenomena, and so that's hepatorenal syndrome. Again, see, these complications are not my today's course. I'm supposed to teach pharmacotherapy. I'm teaching you here like more of clinical pathophysiology here. So I'm not going to go into details, but they can have and read about them. But in hepatorenal, albumin has a role. So if you give albumin, that can improve the outcome. So you can remember about albumin in hepatorenal. No, I'm talking to you because you asked about hepatorenal. Okay, I told everyone, but like you see, was a bit distracted, so I was just trying to. So like albumin has a role. I have a slide in the end. So if this time, I'll talk about hepatorenal as well, which I haven't uploaded, but I have a slide on that. So let's talk about portal hypertension. So this increased portal venous pressure resulting from obstruction to portal blood flow. Okay. And it can have multiple etiologies like prehepatic, hepatic, and post-hepatic. We'll talk about hepatic, which is liver cirrhosis. So because of liver cirrhosis, if there is, and how do we define it? It's a hepatic venous pressure gradient more than 5 millimeters of mercury. And by the time it goes beyond 12, people start developing complications of portal hypertension. So patients with cirrhosis can develop portal hypertension, and complications can be ascites. So now ascites can be exudative and transudative. Again, you are supposed to do that. And all pathophysiology. So you should know and how to differentiate between these two. What are the causes? So just because of cirrhosis, you should get transudative ascites. That means there's more of transudation of the fluid rather than the protein itself. So the protein content is less, and they use some serum, acetic, albumin gradient to differentiate. So there are ascites and then subsequent spontaneous peritonitis. This is one of the complications of portal hypertension. The other complication will be increased blood flow through portosystemic anastomosis of shunts. And I hope you remember your anatomy. Where are those shunts? And one of that shunt is in the esophagus, lower esophagus. So there is varices, and then they can bleed. And there are many other complications of portal hypertension like splenomegaly or hypersplenism. So what do? You need to reduce the portal pressure. So for portal hypertension, the first line pharmacotherapy, you should remember this, is non-selective beta blocker, and which can be propranolol, nodelol, and calvedolol. Commonly used propranolol. Okay, so at least you should remember propranolol. Why non-selective? Why not selective? Non-selective because beta blockers lower the cardiac output, which beta 1, that's beta 1 effect. So it's blocked by beta 1 adrenoceptors. So you are reducing the cardiac output, so you are reducing overall blood flow and pressure. But you need to reduce the portal pressure. So what it also does, there are beta 2 receptors on splanchnic vasculature, which cause vasodilation. So when you block beta 2 receptors, so that leads to splanchnic vasoconstriction. So splanchnic vasoconstriction via blockade of vasodilatory adrenoceptors beta 2 of the splanchnic circulation. So when you cause vasoconstriction in the splanchnic circulation, so there's decreased blood flow in the portal system. So pressure in the portal vein goes down. Okay, so that leads to decreased portal and portal blood flow, decreased portal hypertension. Okay. So mainstay, the primary therapy, first line pharmacotherapy for portal hypertension is non-selective beta blocker, for example, propranolol. And you know why non-selective, so it's explained here. And because, as you know, esophageal varices are a complication, so they are also used to prevent variceal bleeding. So someone who's at risk of variceal bleeding, they are also given non-selective beta blockers to decrease the variceal bleeding. So this is another indication in the same scenario, but not just for the portal pressure, but to reduce the risk of variceal bleeding. Esophageal varices, it's a variceal hemorrhage. So someone who presents with variceal hemorrhage, so they are presenting with upper GI bleeding. So again, there's a separate, I think, surgical lecture with you on upper GI bleed and then the lower GI bleed. So obviously, all this you have to do resuscitation and stabilization, and then you have to, in terms of pharmacotherapy, you can use octreotide. And what's the octreotide? It's a somatostatin analog. Good. So you should read a little bit about how does it work. Somatostatin analog, and you know the somatostatin inhibits everything. It has many functions. One of them is the vasodilatory. So it causes reduced spinal blood flow. If you give octreotide, so it inhibits secretion of the vasodilatory hormones. So it will inhibit release of hormones which cause vasodilation, causing glucose. So it's an indirect splanchnic vasoconstriction, and that reduces splanchnic blood flow, and which leads to decreased portal pressure. So how does octreotide work?
And stop the release of hormones.
So it's a somatostatin analog, and it inhibits the release of
Hormone, which
Good.
causes vasodilation.
yeah. So it's causing indirectly splanchnic vasoconstriction and reducing the splanchnic blood flow and reducing the portal pressure. Good. So it's used in acute situation as well, and for 3 to 5 days. And those who are with bleeding, so it's more of an acute management. When they present beta blocker is more for the prevention. These are for once they present with the bleeding, so then you give them, and then also you give them those who present with variceal hemorrhage. You need to give them antibiotic prophylaxis because they are also at risk of developing other infections, including spontaneous peritonitis. So you have to give them antibiotic prophylaxis. You have to also maintain the electrolytes and vitamins. So you have to give them, if they are alcoholic, so you need to give them thiamine. And to prevent hemorrhage as a prophylaxis, non-selective beta blockers like propranolol, mainly propranolol, but also others. They use a carvedilol, and in cirrhosis is a little bit controversial, so just ignore that. Carvedilol again has a role. It will reduce more pressure, but has other problems as well. Yes.
You need to give, in addition to the oxygen.
Sorry?
You also need to give non-selective.
Yeah, octreotide is more for the acute management. So when they present with variceal hemorrhage, you give them octreotide for 3 to 5 days. But for the prophylaxis, you give non-surgical. There are other non-surgical managements which are not discussed. So there are some other procedures which are done to reduce the variceal bleeding, which other people will talk about. I'm talking about only pharmacotherapy. Ascites. So this is abnormal accumulation of fluid, in the peritoneal cavity, and it can again why these people develop ascites. There are multiple uh, uh, reasons. One is portal hypertension, the other is hyperlipidemia, the third one there's role of some lymphatics as well. So again, you can read about pathophysiology of ascites. And there is some increased nitric oxide in these patients, which leads to decreased flow to kidneys, and then they increase the production of aldosterone, and that leads to more fluid retention and volume overload. So these patients go into volume overload as well. And then you should, again, I won't talk about this, but high versus low salt. Girls, please, we can hear you little bit. So you are having quite heated discussions, I'm saying so. So high versus low salt, like it's a concept that you should know, but like not part of physiology. So those who are ascites, how do we treat them? So we reduce the sodium intake 1 to 2 grams per day. So sodium restriction, reduce sodium intake. If sodium is less than 125 mg per liter, then we need to restrict their free water as well. Free water is like the drinking water, I would say. Because these patients can get normal saline, because usually these patients are hospitalized when they have this much low sodium and they have ascites, and so they will be quite sick. So we restrict the free water. and we give them diuretics. So that's again diuretics are, and there's paracentesis as well, but I won't also. So you can drain the ascitic fluid. Okay. And you can, as a management, you can give them diuretics. Again, you have a spironolactone, which is potassium sparing, and you have furosemide. And you can give one like spironolactone alone, or you can combine it with furosemide. We'll discuss that. And you need to give them IV albumin as well, because they are low in albumin, and once you drain ascites, they will go. So, especially with large parasitis, means when you drain large volume of ascites, suppose if you're draining more than 5 liters of fluid, so you need to give them albumin. And you have to avoid certain medications, for example, NSAIDs or ACE inhibitors, because that again interferes with the diuretic function. So you should know about these diuretics which you have done in renal block, just finished, huh? So you know more than me. So here just spironolactone, it's a potassium sparing. How does it work?
It's antagonizes aldosterone.
Okay. So competitive aldosterone receptor antagonist in cortical collecting tubules, and it is used in hepatic ascites. It's also used as an anti-androgen, also in hyperaldosteronism, also when there's like these patients need diuretic, but they have potassium depletion. Patients with heart failure, it's very important in the management of heart failure. It has been shown to have some benefit. Adverse effects, obviously, hyperkalemia, gynecomastia, menstrual irregularities. The other drug is furosemide or furosemide. So this one is the American version, the other one is the British version. Americans, they call it furosemide. I think the British, they call furosemide, something like that. So it's a loop diuretic. Where does it work?
On the ascending limb.
Thick. So inhibits co-transport system, sodium potassium chloride in thick ascending limb of the loop family. Causes sodium and water excretion, used in rheumatic states, including cirrhosis. So when you need like diuresis, the purpose is to get rid of excess fluid quickly. So when you need quick diuresis, so then you use furosemide. Okay. And so when there's edema, for example, cirrhosis, so you can use that. But again, these patients here because they usually have elevated aldosterone, patients with cirrhosis. So preferred drug is spironolactone. But if it's not working properly, then you can combine it with furosemide. Okay. And adverse effects of furosemide will be ECF depletion, hypokalemia, hyperuricemia, ototoxicity, and hyperglycemia. So monotherapy with spironolactone may be preferable for a new onset ascites, mild ascites, moderate ascites, or as an outpatient. But when you have severe ascites, like then you have to combine. So combination therapy with spironolactone plus furosemide in a 5:2 ratio. So 5 parts spironolactone, 2 parts furosemide. Ratio may be preferable for recurrent gross ascites or when faster resolution of ascites is required for hospitalized patients. Once ascites is under control, taper to the minimum effective dose to reduce side effects. And combination diuretic therapy is associated with more rapid ascites reduction and lower risk of potassium imbalance than monotherapy. Because one causes hypokalemia, the other one causes hyperkalemia. So they kind of balance each other. And the diuretic should be used with caution. Patients with severe hyponatremia, hepatic encephalopathy, or renal function deterioration. So you have to be a little bit cautious. But as long as you remember spironolactone furosemide and you start with spironolactone, if there's too much ascites, if you need quick resolution, you will combine it with furosemide. Okay. Now, spontaneous bacterial peritonitis. It's an bacterial infection of the ascitic fluid in the absence of any focal, intra-abdominal, or surgically detectable source of infection, as I said in the beginning. So any patients who comes with ascites, you always do, even if there's there little, so those patients who have cirrhosis and some little amount of ascites, you drain that fluid. Even if you so draining a fluid is with 2 reasons. One is diagnostic, the other one is therapeutic paracentesis. So even if you don't need a therapeutic paracentesis, you need to do diagnostic paracentesis, and you check 2 things, including you want to figure out if they have spontaneous, because sometimes they don't have any symptoms. They have spontaneous bacterial peritonitis, but they don't have symptoms. So only on lab parameters where you see an elevated neutrophil count, you diagnose them with this. So someone who has cirrhosis and ascites and elevated neutrophil count in the ascitic fluid, you diagnose them with this. Or they sometimes they can have fever, sometimes they can have abdominal pain. Many times they can be asymptomatic as well. So ascitic fluid neutrophil count more than 250 cells per cubic millimeter indicates spontaneous bacterial peritonitis, even if they don't have symptoms. So typically it's a monomicrobial bacterial infection, and gram-negative rods are more common, like E. coli and Klebsiella. Treatment? Any idea?
Antibiotics,
Of course, antibiotics. Which ones?
depending on the.
So you won't know unless you get the culture report, and you won't wait. So which one would you start with?
Give to,
Which one?
give advance.
Cephalosporin. Okay. So you can start with IV third generation cephalosporin. Some references say amoxiclav, but probably not. The preferred one would be third generation cephalosporin, IV third generation cephalosporin, unless you get the culture results. And if it's uncomplicated, because sometimes they can have complications, like they have variceal bleeding, all those things. But if it's uncomplicated, then you can start with fluoroquinolones, especially if the resistance is low in that area for fluoroquinolones. And also, suppose if they have previous history of spontaneous bacterial peritonitis and you have previous results. So suppose someone who has a history of MRSA, so then you want to give them vancomycin. Or sometimes, if depending on previous history, you can give them piperacillin tazobactam. Or you can give them neuropenicillin. So depending on like situation, you can choose different, but as long as you at least remember IV third generation cephalosporin, that should be good enough.
Is it more preferred to use cephalosporin's third generation or the fluoroquinolones in an area that has low resistance?
I said like if there's no complication with the ascites with the spontaneous bacterial peritonitis and there's low resistance, then probably you can use low. Otherwise, they are mainly used for the prophylaxis, and you need to also use IV albumin in these patients. And for prophylaxis, like if you want to prevent the spontaneous bacterial peritonitis, those who are at high risk, suppose who are presented with variceal bleed, you can use ciprofloxacin or some other drugs as well. Okay, but at least you should remember for the treatment, IV surgeon cephalosporin. You have other options like piperacillin tazobactam, you have meropenem, you have patients who have history of MRSA, you can use vancomycin. Okay. Okay. Now, very important topic, hepatic encephalopathy and portosystemic encephalopathy. It's a spectrum of potentially reversible neuropsychiatric abnormalities seen in patients with liver dysfunction and portosystemic shunting. Why does that happen? Because cirrhosis leads to decreased hepatic metabolism or detoxification of different substances, and also there is portosystemic shunting, which bypasses the liver, and that leads to accumulation of neurotoxic metabolites, especially ammonia. Ammonia can cross blood-brain barrier, also can get absorbed through the gut. Ammonia, but ammonium cannot. So if you can convert it to ammonium, which is NH4, so you need more hydrogen. If you have more hydrogen, you can convert it to ammonium in the gut. Because where is this ammonia coming from? Any idea? Has been produced in the gut, and then it gets absorbed. These things. So also hypokalemia and metabolic alkalosis increase the risk of hepatic encephalopathy. Again, for the same reason, when you have metabolic alkalosis, so you have less hydrogen to convert ammonia to ammonium. Hypokalemia also leads to, because when there's low potassium, so potassium comes out of the cells, and in exchange hydrogen goes to the cells, so there's more intracellular acidosis, which in kidneys leads to more production of ammonia. So, and there are obviously precipitating causes of hepatic encephalopathy, which you should do in your pathophysiology. So, and you should know where is this ammonia coming from, like what is its supply and where it's produced and where is it cleared. That's more of a pathophysiology. As a treatment, so you have to identify the precipitating cause and you treat. So, if it's infection, you treat infection. If it's variceal bleeding, you take care of the variceal bleeding. Okay. And you take measures to lower the blood ammonia concentration. So obviously, when it gets in the blood, so it gets to the brain. So you need to reduce the blood concentration. How do you do that? You prevent its absorption with medications such as lactulose or rifaximin. So these are the drugs which you should know, okay? And you also correct the hypokalemia, and you also generally don't restrict protein, dietary protein in them. Like you don't give them excess protein, but you don't restrict their protein consumption. In the past, we used to do that. Now it's not recommended. So you should know what lactulose and lactulose is similar. Okay, so both of them are similar. It's this just a little bit. One is form of fructose, the other one is form of sorbitol. So this is synthetic disaccharide laxative. So they are, you must have done in the laxatives, huh? You have done this, huh? Good. So again, do it here as well because it's been covered in 2 lectures. So people might ask about this. You never know. As a first line treatment of hepatic encephalopathy. Remember, first line treatment of hepatic encephalopathy is, and in terms of pharmacotherapy, what is the first line drug that you give? Lactulose, huh? Lactulose or lactulose. Because here we are talking about lactulose. So it's the first line treatment given orally, can be given as an emas. Dose is titrated to achieve 2 to 4 soft stools per day. How does it work? It improves the hepatic encephalopathy by decreasing absorption of ammonia in the bowel, thus decreasing plasma ammonia concentration. Side effects include abnormal cramping, diarrhea, flatulence. So what happens? Lactulose is converted to lactic acid by intestinal flora. So it becomes an acidic thing. So there's acidification in the gut, which favors the conversion of ammonia to non-absorbable ammonium. Ammonium, which is NH4, is non-absorbable. So when you have acid in the gut, so it converts ammonia to ammonium, so it doesn't get absorbed. So ammonium is excreted in the feces, so reduces plasma ammonia concentration. That's one thing. There are other effects that contribute to clinical effectiveness of lactulose and lactulose, and which include modification of colonic flora, and it displaces the urease producing bacteria with the non-urease producing lactobacilli. The other thing that it does, it's just because it's a laxative, so it's a cathartic effect. So the transit time is reduced. So the contents in the gut, so the feces don't stay long enough in the gut to have this ammonia getting reabsorbed, getting absorbed through the gut. It doesn't allow that much enough time. So this cathartic effect of the hyperosmolar load in the colon that improves the gastrointestinal transit, that means it lowers the gastrointestinal transit, allowing less time for ammonia absorption. The other thing is it increases fecal nitrogen excretion due to increase in stool volume. It increases the incorporation of ammonia by bacteria for synthesis of nitrogenous compounds, and it also reduces the formation of potentially toxic short chain fatty acids. So it does multiple things. But as long as you remember that it leads to acidification of the gut, so it leads to conversion of the ammonia to ammonium. Okay, and it also modifies the colonic flora, and it also leads to cathartic effect, a laxative effect. These three are very important. Okay. Antibiotics, as a general rule, antibiotics are added to one thing is antibiotics for the chronic bacterial pneumonitis. Here we're talking about hepatic encephalopathy. Yeah? So again, when the lactulose is not working, then you add antibiotics. You don't replace lactulose. So you still continue with lactulose, but you started somebody on lactulose in 48 hours. If they did not respond, you add antibiotics. Okay. So they are added to lactulose or lactulose. And the most common one is these is now rifaximin. Previously, it was metronidazole and the other antibiotics, but now rifaximin is recommended therapy. It's a broad spectrum, non-absorbable oral antibiotic. How does it work? It inhibits bacterial RNA synthesis. How? By binding to bacterial DNA-dependent RNA polymerase. So it inhibits RNA synthesis in bacteria. And that leads to reduced number of ammonia producing intestinal bacteria. So when you have less bacteria because they are producing, so you have indirectly reduced serum ammonia level. So you have less production of ammonia, and so you have less ammonia level. And recommended for patients without improvement in mental status within 48 hours after starting lactulose, or who cannot take lactulose. Somebody who cannot take it, then again you have to give the person. And may be added to lactulose to prevent recurrent episodes of hepatic encephalopathy after second episode. Other antibiotics include neomycin, vancomycin, metronidazole. They again reduce the gut flora content or gut bacterial load. Okay, is that much clear? And there are other substances that can also be used to decrease the ammonia levels, which include L-ornithine, L-aspartate, and trans-chain amino acids. Is any questions? And you had, somebody had a question on hepatorenal syndrome. So hepatorenal dysfunction in patients with advanced liver disease. And in pharmacotherapy, you can give octreotide, midodrine, and albumin, and those, because there's renal dysfunction, and then you can go to vasopressors. So albumin again has a big role here, besides vasopressors. And then the primary biliary cholangitis, again, then you have a role of sodium-oxycholic acid. I am not covering this today. These are additional slides, so they are not uploaded over there. Okay. Also diol, and then there's, you can, because they're co-writers, so you can use other drugs as well. Now some people will start coming in for the attendance. See, I just want to see who are showing up. You can do it. Oh, okay. I need to stop recording.
Yeah.
From where?
You can stop sharing.
Oh, yes.
And the meeting.